Hello and welcome to Leicester Royal Children's Emergency Department. My name is Catherine and I'm one of the Paediatric Emergency Consultants here. This is a quick reference guide. Now it's intended for ST4 pluses, so if you're one of the FY2s or CT3s, then please have a look at the other guide which is labelled as FY2/CT3. So the aims of this talk are quite simple, just to welcome you and introduce you to our department, the way it works, how things go, and a little bit about what you'll be doing here. Hopefully this will enable you to see the opportunities here and do some early goal setting about what you'd like to learn and what you'd like to get out of it. You're going to be part of quite a varied junior doctor team here. So we have paediatric trainees doing their EM subspecialty training and EM trainees doing their paediatric subspecialty training. Both these groups are training to be paediatric emergency medicine consultants, but are from two different disciplines. We also have paediatric registrars who are just rotating through, EM registrars who are just doing their paediatric block. We have people who are on PEM UPs, and that includes our education fellows. And we have CT3s in EM. We have FY2s, GPVTSs, ACCS trainees, and junior trust grades. So as a department, we are a standalone children's emergency department. That means the children stay within our department and they're completely separate from the adults. However, in practice, we're co-located. We're linked to the adults just by a corridor. And we all work together. We use some of their staff, including their consultants and junior doctors. We also use their nursing staff and HCAs. We work together. However, obviously all our admitted patients go to the children's hospital, so we link both to the children's hospital and to the emergency department. All our guidelines too we try to keep them in lines with the children's hospital because we want to ensure continuity for our patients. We are a tertiary centre, and of course we're part of a network, more than one network in fact, so obviously the intensive care network, the trauma network, and the local emergency medicine network. We believe that we can give you the best of both worlds. Normally we're really quite busy, one of the busiest in the country, but of course COVID has affected our numbers. So, patients can arrive in two ways, either they walk or they arrive by ambulance. If the child is really sick, EMAS may choose to pre-alert us, in which case they'll go directly to the emergency room. For less sick patients, they'll go directly to the nurse coordinator who will go through the COVID sieve process and ask them to go to reception and book in. Patients that walk in accompanied by their parents will go through the COVID sieve to reception and book in. The sieving process will enable them to be triaged into blue or red. Now, blue is no COVID symptoms and red is COVID symptoms or a family member in isolation. They will then be put into triage where they'll be streamed to either injuries or majors or / illness. And both the blue and red areas have injuries and majors areas. Blue and red areas are physically separate and at different ends of the department. So patients come in from a different entrance and will exit from a different entrance, and you'll see this when you arrive. Once they've been triaged, they'll be allocated to medical assessment, investigation and treatment. In short, one of you guys will be seeing them, or one of us. So, we'll assess them and then make a decision about where they need to go, whether they need to go home, whether they need to be admitted or whether they need to be transferred out for further treatment. And ideally this all happens within 4 hours. It does look a little bit complicated, and we also do it with two teams. So we operate what's called a single front door here, which means all the acute paediatric admissions come via ED. So we have a paediatric team based in our ED who see our patients with us. We don't separate the patients out, although obviously they do tend to see illness rather than injury. Just be flexible with what you ask them to do and be flexible with what they ask you to do. We are working together. So your clinical role is to cover all of this really. So you'll be seeing walk-ins, you'll be seeing ambulance referrals, you'll be asked to go to resus, blue zone and red zone. Obviously, if you've had some kind of occupational health assessment which says that you can't work in any of these areas, then please do let us know and we can allocate you appropriately. Remember, so you're a senior doctor here now. So you may well be the senior decision maker on the shop floor, whether this is reviewing patients or making senior decisions for your own patients. And you'll be asked to support other staff. Now, this doesn't just mean working with the nurses, but also supporting the junior doctors. Of course, we're here to support you too. You're not alone. Particularly on nights, you'll be doctor in charge and you'll be running the whole department. You'll be asked to have an overview of all the patients in the department and what's happening with them. It is worth spending some time during the day learning how to do this and learning effective ways of delegation and all of those types of skills. and we can give you feedback on how you're doing. Your role may be to provide specific skills that you as a senior doctor have. So, for example, femoral nerve blocks, reducing fractures. We do a lot of ketamine sedation here. And we will support you in gaining those skills and in providing those skills. We don't have very many hard and fast rules within our department because it's a fairly dynamic environment, but we do have a few. Any safeguarding concerns must be discussed with an ST4+, any at all. So please expect to hear from other members of the team about their safeguarding concerns. Obviously, if you're not sure what to do or you're still concerned, then please discuss it with one of us. That's absolutely fine. Anyone on their third attendance for the same problem must be seen by an ST4+. The reason for this is that anybody coming 3 times with the same thing, either we've missed something, or maybe we've not managed it right, or there's a perceptual problem, and all of these need a bit of senior input and some tact. All children under 1 year must be discussed with an ST4+, and all children under 3 months must be reviewed by an ST4+. And the reason for this is just for risk stratification. Not everybody that you'll be dealing with will have had any paediatric experience at all, and so just be aware of that when you're reviewing and seeing patients. If you've got further questions after you've seen them, then of course come and find one of us. We discuss things with each other all the time, and we want you to feel free to do the same. Please don't forget the UTI folder. Again, there's not many things that we need to do on a daily basis in the emergency department, but please don't forget the UTI folder. Essentially, children who have recurrent urine infections may need follow-up as per NICE guidance, and the UTI folder will take you how to do that. So anybody who is suspected of having a urinary tract infection needs to go in the UTI folder, and you can find it on the floor. Lastly, don't panic. Yes, you're being put in a job where you may be in charge of one of the largest children's emergency departments in Europe, but you are never alone. So this little picture is just a picture of the day team and the night team handing over in the morning, and that's just our children's emergency department team. Of course, there's the CAT, PICU, and of course the doctor in charge next door to ask, who we refer to as EPIC. If there's any problems, then please say, find one of us on the floor, bring up a handover, or just email one of us and say that you need a chat. Say you need a coffee. We've all been there. We all know what that is. We really do want to hear from you if there's any issues, so please let us know. We really look forward to working with you, and I'll see you on the shop floor.